Now we will move on to our next session. So our next speaker is Dr. Rajiv Kovil. He is from SL Raja Hospital, Mahim, Fortis Hospital, Mumbai. He is a senior consultant, Department of Diabetes and Endocrinology. So over to you, sir.
Thank you. Thank you, Dr. Patel. Thank you, all the organizers, for bringing me here. And thank you for accommodating a last minute jugglery. So what is primary in diabetes management? I could see that, my forces made Dr. Easwar's computer also go skyrocketing. So mortality in people with diabetes, major cause of death, the cause of death seems to be higher in patients with diabetes than people with stroke and cardiovascular disease. But one thing that Ishwar will speak about is that people with diabetes are dying of cardiovascular disease only. When you need to understand that only 40% to 50% of patients actually die of cardiovascular disease in patients with type 2 diabetes. But the morbidity associated with many of the complications, whether it's retinopathy, nephropathy, and peripheral neuropathy and diabetic foot infections, is very high. And diabetic foot infections can lead to handicap, and the quality of life itself goes down. So one is morbidity and the other one is mortality, and diabetes actually worsens the morbidity in patients more than the mortality as such. And what does the International Diabetes Management Practical Study shows? That 20% of Indians have not been screened for cardiovascular disease. 30 to 35% of type 2 diabetics have not been screened for microalbuminuria. They have not been screened for retinopathy, nor have they been screened for neuropathy. Today, this pandemic has taught us that hyperglycemia by itself is a huge risk factor for an infection-related death. And we've been saying that the diabetes is an immunodeficient disorder, probably second to HIV and probably second to immunosuppression. But diabetes is an immunodeficient disorder. This pandemic taught us that just inpatient hyperglycemia or hyperglycemia at admission in hospital is in itself a huge risk factor for adverse events following hospitalization due to COVID. It also told us that pre-infection glycemic control in diabetics, and if you look at A1C more than 7.5 versus A1C less than 7.5, the deaths due to COVID do go up. Now, why achieving goal is important? Because patients who are not at goal have a fourfold higher risk for MI, eightfold higher risk to die, leading cause of blindness, one-third cause of legal blindness, end-stage renal disease. So there's a reason that we need to reach goal. And UKPD has told us that 1% can cause a reduction, 1% drop in HbA1c can cause a 21% reduction in diabetes-related death, 37% reduction in microvascular complication, 14% non-significant reduction in myocardial infarction. So hyperglycemia is a cardiovascular risk factor by itself. So why do we need to treat other cardiovascular risks when hyperglycemia by itself can impair platelet function by all these factors, which out of which activation of PKC and increased reactive oxygen species and the non-enzymatic glycation is very, very important of glycoproteins. Now, if you look at cardiovascular disease itself, almost 70% of patients across the globe with any kind of cardiovascular disease have some form of dysglycemia. Either they are diabetics, they are pre-diabetics, or they are somewhere in between, which actually means that diabetes seems to be the driver for cardiovascular disease rather than the other way around. So if you have to prevent cardiovascular disease, we have to treat dysglycemia. We have to treat the insulin resistance which leads to dysglycemia. The EPIC Norfolk study done in Norfolk, which was a prospective study which followed a cohort of 30,000 patients, both men and women, and looked at the risk of, of cardiovascular risk and the risk of getting cancer over 30 years, showed us that for every A1C increase, the risk for cardiovascular disease increases. Similarly, this retrospective data says that delay in therapy intensification within the first 6 months to a year of diagnosis of diabetes can lead to adverse cardiovascular events. And this is what is about glycemic memory. where hyperglycemia may imprint upon cells of the vasculature and target organ. So if you have early good glycemic control, it would have long-standing benefits and emergent risk reduction in patients with type 2 diabetes. Now, the most important question is that although lowering glucose will help in symptoms, is there enough evidence to target A1C to target cardiovascular risk? But you look at it the other way around. If we do not consider reducing hyperglycemia as primary management of patients with type 2 diabetes, consequences are terrible. And let's discuss this truth. Now, these are all studies, strategy of glycemic control, and whether we can have benefits on intensive versus conventional control on micro and macrovascular complications. And if you look at it, the main inclusion criteria, UKPD has looked at patients who are newly diagnosed within 6 months, and advanced ACCORD and VADT looked at long-standing diabetic with at least 8 to 10 years of diabetes with either established cardiovascular risk or with cardiovascular risk factors. Now, UKPDS did tell us that a 1% or a 0.9% reduction between the intensive versus conventional did reduce microvascular complications. But what we are actually interested in, the heart disease, the MI, and the macrovascular event, there was a non-significant reduction. Now, if you look at this study published again 2 decades back, at almost near normal HbA1c, the risk for MI is 2 to 3 times that of a microvascular event. Now, we need to understand that vascular disease begins early, and it's because of insulin resistance, and that's why we need to treat insulin resistance and glycemia very, very early. Macrovascular disease occurs at a much lower glucose threshold, and it's influenced by multiple factors. Steno 2 was a very important study which looked at multifactorial intervention, and it showed that multifactorial intervention can cause a reduction in cardiovascular event, cardiovascular death, all-cause mortality. And today we have a 20-year follow-up of the Steno 2 still showing emergent benefits. The ACCORD was like going like cowboys. If we could go down to a normal control using whatever is available, and target an A1C less than 6%, and looked at it also a blood pressure cohort or less than 120/80, and addition of fenofibrate versus placebo in patients who are already on a statin. But you require to know that patients were long-standing diabetic and had at least majority of them had established cardiovascular disease. Obviously, the intensive control harm had to be prematurely stopped after 1.8 years, 1.9 years, purely because of an increased death rate and increased event rate. But if you look at, or if you try to slice the analysis of the ACCORD study, and you see, look at the HbA1c, patients whose HbA1c was less than 8% had actual benefit from intensive lifestyle as compared to patients who had no whose HbA1c was higher. Again, patients who had no previous cardiovascular event benefit with intensive control. So again, the two take homes from ACCORD also, that patients who were well controlled did benefit from intensive control, and people who had no previous cardiovascular event again benefit from intensive control, again telling us that we need to get intensive in our approach very early or on in diabetes, rather than look like the cohort of the ACCORD study, where it's like a fast moving train and we are trying to pull all the brakes together. Advance also looked at the composite of macro and microvascular events and death from CV, non-fatal MI, and non-fatal stroke. It had an inadequate statistical power to detect reduction in microvascular event. The annual rate of 2.2% was of events was lower than the anticipated 3%. If you look at the VADT, again suffered from the same problem, that it shows that glucose plays a very important role in lesion initiation, and lipid may play a role in lesion progression. Now, the UKPDS follow-up after the trial ended in 1998, 1,000 of the participants were then followed up for 10 years, and even if the control were lost, what was seen is that patients who were well controlled initially and had then almost their HbA1c had synchronized with patients who were in poor control. There were emergent risk reduction in what we were really worried about, which was non-fatal stroke and non-fatal MI. And this is what we call as the legacy effect. So what, again, the hypothesis was that you control diabetic patients early, risk reductions or cardiovascular event reductions in patients by treating hyperglycemia does not come around in the first decade or so. It requires minimum 15 to 17 years to bring about a consistent change, and that's what this UKPD's legacy effect again showed us. Now, if you look at a meta-analysis again published in Diabetologia a decade back, because there was a lot of cobweb a decade back that whether we should control patients intensively, again tells us that intensive control favors in spite of there being an adverse event in the ACCORD study. In summary, I would say glycemic control plays a very important role in reducing cardiovascular complication. Benefit becomes evident only after a long period of time. Follow-up periods in ACCORD and VADT were 3 to 5 years. We should look at least 10 to 15 years. And follow-up required to demonstrate macrovascular benefit in UKPDs was 17 years. So if you look at this type 2 diabetes causing all these issues related to oxidative stress, mitochondrial dysfunction, inflammation, and other mechanism causing cardiac dysfunction, it's very important that we try to reduce the state of hyperglycemia with early intervention, and future complications can be prevented. So primary in patients with diabetes, type 2 diabetes, and type 1 diabetes is managing their metabolic problem, which is hyperglycemia. Thank you so much. So again, I would summarize that hyperglycemia remains cornerstone of treatment. Microvascular complications are common in patients. Improved control lowers the risk of micro and macro, and every 1% drop is associated with improved outcomes over a long term with no threshold effect. Thank you so much.
So our next speaker is Dr. TKM Easwar. He is a consultant diabetologist in AIIDR Diabetes Center, Rajkot. So over to you, sir.
Am I audible?
Yes.
Okay, thank God. Okay, so I was going to be the first to speak on heavy ASCVD risk reduction, but because of this technical glitch, Rajiv got to speak.
That is my tantric powers.
Yeah, but see, that's what, So when I went to the internet and tried to find, I didn't get my image. There was just my name, but there were so many images of Rajiv. So I was wondering how big can this Goliath guy be? And through his powers, he made himself speak first and he made me speak second. Now, if you see the top 10 causes of death in India, and which I'm sure is all over the world, you will see that diabetes goes way below. Ischemic heart disease is 15.4%.
Sir, you need to share your slides.
Slides are not visible?
No, sir.
Oh, I'm sharing it, but it's still not visible. Yeah, I have sent the slides, Mayur?
Yes, sir. We will share the slide.
Yeah, you share it. I'll just tell you to change. Something is wrong today.
Tantric power, sir.
Yeah, Rajiv made some.
This is called black magic.
It is called, I don't know what magic it is.
Okay, sir. Can you see the slides?
It is visible. Now go ahead, sir.
Okay.
Yeah.
So can you change the slide? Okay. So I'm a small David against the Goliath, and I hope that with this few slides I'll be able to prove to you that even Goliath can be defeated. Next slide, please. So as I told you, the burden of ischemic heart disease is highest in India. It's 15.4%. And there are so many other diseases which follow, and diabetes comes quite low at 2.5%. And these are from the WHO global burden of diabetes. And so though we have got tuberculosis, lower respiratory infection, diarrheal diseases, a lifestyle disease like diabetes comes last, while something like ischemic heart disease comes much ahead in the list. Next. Next slide. So if you see the vascular and non-vascular causes of death among people with diabetes, which was mentioned in the death certificate in the United States in 2008, you will see that most of the people died of vascular causes of death: ischemic heart disease, cerebrovascular disease, congestive heart failure, other heart disease, accounted for more than 50% of the deaths of people with diabetes. So it's very difficult to say that this is not a very important thing. It is the most important thing. Usually people with diabetes will die not because of their sugar, but because of the complications caused by sugar. And ASCVD is one of the most important reasons that if it is not properly prevented, can lead to death in these people. Next slide. So if you see prevalence of coronary artery disease by diabetes status, age and sex, again in USA, this shows they did a survey between 2009 and 10. You can see that both in men and in women, once you get diabetes, then the chance of developing coronary artery disease increases, almost 10 to 20 fold. And these are the people who are going to develop some cardiovascular complications and die because of that. Next. So if you see the risk factors of CVD also, you will see that smoking, of course, it has come down in the USA, but dyslipidemia, which is in the green, it goes up right from 15% to 35% in the last 10, 15 years. It has emerged as a very important risk factor. While if you see the same time diabetes, it's not emerged as a very important factor at all. It's just gone up from 0 to 10%. So though both the diseases are going hand to hand, you can see that, as far as dyslipidemia is concerned or hypertension is concerned, they are much more important as far as prevention of the CVD death is concerned. Next. So what are the CVD or CHD risk equivalents? We know that clinical coronary artery disease, symptomatic coronary artery disease, PAD, abdominal aortic aneurysm, and chronic kidney disease, all of these are a part of the CHD risk equivalent, but diabetes mellitus also is a part of the same. Next. And why it is so? Because of this very famous slide of the Easwar study, which showed that the person who is having diabetes and who has had a stroke, who has had a fatal or non-fatal MI, he has the same risk as developing a second myocardial infarction as compared to a person who has diabetes. So if I don't have diabetes and I develop a non-fatal MI, then my chance of developing a second MI in next 7 years will be the same as that of a diabetic who has never had an MI at all. That's why they said that diabetes and CHD are risk equivalents. Both are around 20%. Next. So will tight glycemic control really benefit, or does it do more harm and good? So here we are debating whether we need to control the sugars more aggressively, or whether we need to take care of that. So most previous studies have examined 1 or 2 of these risk factors, but not all the 3. And this study in 2013 examined all the 3 risk factors. It included 26,000 people with diabetes. People with diabetes are focused on controlling their blood sugar, but their study found that controlling blood pressure and cholesterol is even more important in preventing heart disease. So even in a person who is having diabetes, always the ABC is first you control the lipids, second you control the hypertension, and third you go for the sugar control. Next. So this is another very important study which was published just last year. Impact of intensive glucose control in patient with diabetes mellitus undergoing percutaneous coronary intervention, 3-year clinical outcome. And this was done in China, and it showed very clearly that intensive glucose control for 3-year follow-up period in diabetic patients after PCI was not associated with better clinical outcomes than lenient control. So if you really see, then sugar control is important. I'm not saying that we don't want to just leave the sugar as it is, but that is not the thing which will prevent the death or which will prevent the cardiovascular event from occurring. Next. And you can see another study from Diabetes Care in 2016 that if you reduce glucose intensively, of course, we know that microvascular disease reduces. There is no doubt about it. But to have a favoring benefit in reducing the CVD, there are so many other things. We also need to treat the other risk factors. There is drug-associated hypoglycemia. There is drug-associated weight gain. The more the number of drugs you give, there are more drug-drug interactions. Also, if those who are having a shorter life expectancy, we don't want to have a very, very tight control of HbA1c because there is a very high chance that they will die because of some other problem, especially from hypoglycemia. Next. And as Dr. Kovil also talked about ACCORD Advance and VADT, but again, it showed us, though somebody may say that the choice of the population was wrong and these were people who are having diabetes for a very long time. It just showed us that, if you have a tight control of the diabetes, the microvascular complications will definitely come down. But as far as macrovascular is concerned, there is a very big question mark about really whether it's going to help or not. Next. And this is what it showed that, if you see, take-home message was that ACCORD reduced the risk of MI, but increased death risk in intensive arm because of the complication. That's why it was stopped in advance. In ACCORD, in advanced glucose control has no impact on CV events, and VADT also glucose control has no impact on CV events. Next. So who will benefit from tight glycemic control? So Accord Advanced VADT, again, as Rajiv said, yes, there will be a good benefit of glycemic control, but it's after a long period of time. And follow-up time to demonstrate macrovascular benefit in UKPDS was 17.8 years. So rather than do that, why not do something else? Why don't you control the lipids? Why don't you control the blood pressure so that immediate results are evident rather than wait for such a long time? Next. What are the studies? Dr. Kamlesh Khuti is well known to all of us, gave a lecture in 2019, and he said that trials have supported that reducing glycemia definitely has an impact on microvascular complications, but we really don't know what is going to happen on microvascular complications. And those who have got a longer life expectancy will benefit the most from tight control. We know about that. We also need to understand that if we try to achieve near normal HbA1c levels, then the prognostic markers like hypoglycemia will come out, and these are all the things which may lead to poor outcomes. So we need to set individual targets at, for hypoglycemia. It's not like that for lipids. Lipids are low risk, moderate risk, high risk. It's very clear. Blood pressure targets, just we had a debate, it's quite clear. But for sugar, we are having different targets for different set of people. For some, we are saying 6.5, for some, we are saying 7, for some, we are saying 8 is okay. So that itself shows that sugar control is not that much important as much as lipid or blood pressure control is. Next. And this is one slide back, please. So this is another article which came in 2019. Historically, they say that the strategy to reduce complication of type 2 diabetes has been intensive glycemic control, but evidence shows no meaningful benefit. And so they also say that patient-centered care, we need to shift from a glucocentric view of diabetes management, which now definitely we are not doing. We are now looking at all the other things and definitely try to prevent hypoglycemia so that that complication is avoided. At the same time, trying to aggressively treat lipids and blood pressure so that the ASCVD mortality is reduced. Next. And this is another paper by Dr. Hong, which was published in Journal of American College of Cardiology in 2017. Again, they also say that although glycemic target is important, target should be achieved slowly. And so if you're going to do something slowly, if the person is having a ASCVD or something like that, and you aim for 7 to 8 years of control, I don't think that makes any sense. You need to, definitely do something aggressively so that that risk comes down, especially one who has undergone a PTC or a bypass, or who has had an event in the past. If you say that now we'll try to bring down your sugar slowly, it really doesn't make any sense. Next. And so that is what this triangle says, that the primordial prevention is the health behavior, the primary prevention is dyslipidemia, hypertension, diabetes, and metabolic syndrome. And then what we are trying to do is to prevent CVD, CAD, PVD, heart failure, and cerebrovascular disease. Next. But if you see, lifestyle intervention will come for hypertension and diabetics if there are no risk factors. But even if there are no risk factors, if there are comorbidities, if there is diabetes, if there is end organ disease, if there are genetics, strong family history, then hyperlipidemia should be treated. So statin therapy is warranted even when in diabetes only lifestyle is warranted. So this just goes to show that to prevent the CVD risk, there's more focus on giving statins rather than on getting the blood pressure or diabetes under control, especially the diabetes. Next. And if you see the studies that change practice, this is a discussion of about 10 years of the studies which change the way we think. And we know what they say is that we need to increase efforts to prevent type 2 diabetes from occurring in the first place and aggressively treat and control CVD risk factors in those with diabetes. Statins currently represent the main treatment for diabetic dyslipidemia and have shown to be well tolerated and safe. Next. So I would like to conclude that with the overwhelming evidence available to us, ASCVD reduction is much more important versus just aggressive blood glucose control, and this goal should be pursued first. Thank you so much.
Any questions from?
Let us have a quick rebuttal by Dr.
Am I
Rajiv
audible?
Kul,
Yeah. So again, my very good friend Easwar, who's a very, very nice friend of mine, did not actually help any of them watching that whether we should go after cardiovascular disease risk. Now, one needs to understand that we have followed herd mentality in India. What the US does, we have a reactionary approach to it. So the US, in the US, they again follow herd mentality. They made something like metabolic syndrome and they crashed the mountain. Then they said that metformin should be banned. They made metformin. And when metformin came in, it became the highest written prescription. They said intensive control is bad. You should not go take intensive control because of Steve Nissen's rosiglitazone fiasco. And a decade later, they get back rosiglitazone into the market. So again, the US looks at a herd mentality. We as good practicing clinicians, and again, this whole ASCVD, heart failure, elephant in the room is completely pharma driven. What is diabetes? Diabetes is hyperglycemia. Had we ever heard of ASCVD, heart failure risk, look at CKD. Look, this is all pharma driven based on GLP-1 and the SGLT2s, which have driven this market. We as good practicing clinicians, our job is to make sure our patients have a long life, a good quality of life without hypoglycemia, good HbA1c, and also prevent their mortality. From this standpoint, hyperglycemia comes much, much ahead. With all the guidelines that these people give are guidelines to fail. They tell you to add one drug till it fails, then add another drug. Why not add multiple drugs at one go? So good people, I know Easwar in his mind agrees with me. He's a very good clinician that we should again target the basic. So if a patient comes to you for headache, you will not say whether your urine is fine or whether you have backache. So a diabetic comes to you with a complete confused mind, with hyperglycemia. You don't tell him that I'm going to add a statin for you. I'm going to add an SGLT2 because the chance of heart failure is there. I'm going to add a GLP-1 because you will get atherosclerotic cardiovascular. You treat his hyperglycemia. And if you treat his hyperglycemia well, because today we have agents which are insulinotropic, you can maintain euglycemia in patients with TZDs, with metformin, with SGLT2s, with GLP-1 and with DPP-4 inhibitors. With euglycemia maintained, we can prevent the morbidity and mortality related to micro and macrovascular complications. Cheers, Easwar, when we meet again.
Your view, sir.
Dr. Rajiv, point well taken. So we need to, evaluate our patient on, individual basis, and we need to treat the patient accordingly. Thank
Dr.
you.
TKM Ishwar, sir. Your views.
Thank you,
Your
Dr. Easwar and
better.
Dr. Rajiv Kovil for joining with us. And we are very thankful to Dr. Mayur.
Sir, we will give chance to rebuttal to Dr. TKM Ishwar, sir.
Okay.
So just I'll take 2 minutes. Rajiv's background is a wonderful new bridge. It's the Bandra, reclamation bridge. But he's talking all old stuff. That bridge is the thing of developing India, and he's saying that SGLT2 mat use karo, GLP-1. मैंने SGLT2 GLP-1 बोला ही नहीं. I said statin use karo. I never talked about SGLT. I agree that it may be all pharma driven, but statins are definitely not. I am just saying that definitely control your sugar. Use older drugs if you want. Use non-pharma driven drugs if you want. But if you don't reduce the ASCVD risk by giving statins to diabetics, those who really need the statins in the proper dose, if you don't control the blood pressure, they are going to die. They are going to have a stroke. They are going to have a heart attack. So the question is that not only we need to control the sugar, it's like telling, that my mechanic that, aapka engine theek ho gaya, but tire theek nahi hai. So we need to fix the whole thing. And we all know that diabetic patients die because of some complication of the blood vessels. So that is very important. We may not use the pharma-driven drugs until some complication develops. And maybe we should be using more of statins, more accurate control blood pressure, and set the glycemic targets as per the need. I think that will give us a better outcome. Thanks, Rajiv. Nice to see you after such a long time.
Thank you so much, Easwar. Pleasure. Thank you so much for accommodating also. Thank you very much.
Thank you, sir, for this wonderful interaction. And definitely, sir, we will fix a tire.
And thank you for the whole organizing committee of SwasthyaCON. Thank you so much.
Sorry for all the technical glitches in 2 laptops I had. I don't know. Rajiv,
that's the tantric power.
Kerala tantric power is dangerous,
Okay, bye-bye. See you guys.
Thank you.